Then I can do this if you've got a call.
Hello, how are you?
I'm doing a radio check, or can you folks hear me?
I heard you.
Read you 5x5K.
Maybe not.
Yeah, Robert, we can hear you. No problem with that.
Okay.
I think Matt Lindner is waiting in the waiting room.
Yeah, that's on purpose. We just didn't want to talk to him.
I'm trying to figure out who is 347-622-3124. Does anybody recognize that number?
No.
No, I'm not letting them in.
Yep.
Okay, let me pull up attendance.
Murray, what was the number?
347.
622-3124.
622-3124.
You're gonna call him for me?
It's
Dario
Dario
Gonzalez.
Gonzalez.
Yeah.
Oh, we should definitely keep him out then. Damn.
Yeah, leave him in the waiting room.
Sure.
Okay.
Who's getting the envelope of ricin?
I think that going forward, you guys, I think going forward, we should require people to be on video chat. I mean, you don't have to come to REMAC. You don't have to, but you could find a place to sit down with a computer and be on the video
Agreed.
as opposed to be a phone.
Yep,
Yep, and we can see their name and make it's much better.
that's correct.
Yeah, I could set this up so you have to register and people
I think
just.
we'll make that
have to
announcement
register.
tonight that going forward, if we have to be virtual, it's going to be via video, and your video should be on. It's appropriate, you know. Let's pretend that we're in the meeting at the Interchurch Center. That's what I
Yeah.
I pretend that all the time.
Well, then let me go get dinner and get some cheese and crackers or something.
think.
That's right.
You gotta
Oh
go
my
look for
God.
parking.
Yeah. Okay, it's after 5. I'm going to take attendance for medical standards. And who is this? Let me call this person before I start. Hold on. This is annoying me. Now, you know what?
What's the number, Marie?
347-203-8437.
All right, so.
Glenn Asada.
Okay.
I guess we have to let Glenn in. Okay, I'm going to do medical standards attendance, so just please let me know if you are here. Paul Barbara,
Here.
Jonathan Berkowitz,
Here.
Cindy Basilios,
Here.
Harry Koplovich, Joseph Bove, Neil Cemalovic, Wallace Carter, Robert Krupe,
Here.
Jeffrey Douglin,
I'm
Yeah,
standing
Lauren-
in. I'm standing in for Dr. Douglas, Xiwen Lee, and
Xiwen Lee.
Lauren, both of us.
okay. Hold on, I'm just typing in names. Dr. Kosterko, you're here too, right? Reed Caldwell?
Sorry, yeah, Marie, I'm here. I just remuted myself.
Okay, no problem.
Thanks.
Reed Caldwell?
I'm here.
Jason Zimmerman?
I'm here.
Okay. Okay.
Marie, Reed's here. He says he's having trouble with his computer. You got
Okay,
Marie?
no, I
Reed?
heard him.
Cool, cool.
Oh, and Jonathan Washko is here also. Okay. Okay, sorry. Dr. Lobel, David Lobel? David
Maria,
Eng?
I'm here.
Oh, you
Yep,
are?
I'm here. Yep.
Okay, and Dr. Eng, he's your alternate?
This is Dr. Eng. Yeah, me and
Oh.
Matt Friedman are both down as alternates.
Okay. Is Dr. Freed there too? Or is it just you
That's
two?
the last name.
Okay.
I'm here.
Okay. So that's why I have both of you here. Okay, Jeffrey Rabrich. Thank you. Mike Redlener. Joseph Schenker, I know, is here.
I'm here. Right back.
Don't sound so happy, Joe.
No, I was on the phone with to ask him the question about whether we can start REMAC early. Unfortunately, because the meeting time was sent out, it has to, the REMAC voting can't happen until 6.
Okay.
And we fix
Um,
the next one and send out at 5. So we can
What we can do is we can send out that REMAC will be beginning as a joint meeting earlier, and once it's sent out in advance that REMAC is starting early, then it changes the rules.
Okay.
The calendar went out as 6, it's 6.
Tony Shalish. Rafael Torres. Nick Alexandru.
I'm here, Marie.
Hi, Nick.
Hi, Marie.
Glenn Asada.
Here.
David Benelli. I know Dario is here. Doug Isaacs.
I think he's actually in the waiting room. He's waiting to be let in right now.
Should we let him stay there?
Keep them there. Keep them there.
Keep him in the waiting room.
Okay, so where is, for goodness sakes, here it is. Okay. Sorry, I'm just admitting people. Okay. Sorry, just. Okay, so I guess everybody's on the way in. Okay. So Doug is here. Bradley Kaufman,
Here.
Annemarie Girgenti,
Here.
Kevin Ward,
Here.
Grace Cacciola, I know I saw you.
Here.
Madeline Fong,
Here.
Sean Graves,
Here.
Michael Vatch or Robert Ackerman, Morty Lax.
Here.
Hi, Morty. Art Cooper. Robert Goldstein. Can someone from fire department send Dr. Prezant the link to this meeting, please?
I'll take care of it.
Thank you. You did your Langsam?
He's not here. He'll be on in a little bit, Marie.
Okay. I was pretty much. Lewis Marshall. I know he said it'd be a little late. Kevin Munjal is here, right? I thought I saw him.
Oh, hey, it's Robert Ackerman. I think I missed the roll call.
Okay, great. Thanks, Rob.
And hey,
Jessica
this is Kevin Munjal. Hey.
Hi, Kevin. Jessica Van Voorhees. Okay. Okay, so we're all set with medical standards. While I'm here, let me just do I guess I can hold off on the REMAC, I guess,
We'll
huh?
wait till 6. What I would like to ask everybody, and I mentioned this earlier, going forward, if everybody could be on the video, the advantage of that is twofold. Number one, instead of having to go through for medical standards, which doesn't have to be read into anything, Marie could look at the participant list and know who is here. And number two, we all commit to going to REMAC. We take extra hours to drive there. I think it'd be possible for everybody to get to a computer and have this kind of as face-to-face as we can going forward. So obviously now, that's something that we need to try to do. All right. And then I guess, David, you can take it away. Dave?
Oops, I'm unmuted. I apologize. Sorry. Now you can hear me. Marie, one thing, Martin Grillo sent an email saying that he can't access the YouTube
He's not
stream.
a member. He is not a member, and I've sent him the link to the YouTube page so he can attend that way,
Yeah, he
along
says
with
he
all
can't
other
access it. Yeah, I know. That's fine. I actually could access it from the office, so I don't know where the issue is. Before we start, Paul, Barbara reminded me, and last Saturday was 3 years for the passing of Dr. Guttenberg. So if we could just give a moment of silence in his remembrance.
3 years.
3 years. 3 years.
3 years.
3
Yes.
years.
3 years. Yes.
Wow, 3 years already.
Wow, yeah.
So we'll proceed. I think it's appropriate to mention Dr. Guttenberg because we're also bringing the pain management protocol that he asked not to forget And we're bringing this forward tonight through the protocol committee meeting. So let's start with our agenda. Approval of the minutes. Marie sent out a couple of days ago the minutes for our last meeting. If there's anyone, instead of doing any voting, I'll just ask if there's anyone that wants to change anything, anyone who objects, then please speak up now. If not, we'll assume that the minutes are approved. Okay, good. So moving forward, let's go to the correspondence report. Marie, I believe you sent that out as well, but if you could just read that out loud.
Sure. Give me 1 second and let me get it. Okay, 1 second, sorry.
Sure.
Okay, the correspondence report. For membership, we have no new information. From Fire Department EMS, no new information. New York State, sorry, I have to let 2 people into the waiting room. And come on, where are you? Sorry. Okay, I apologize, this stupid thing. Open up. Okay, from New York State, statement of charges from the New York State DOH against Bensonhurst VAC, which has been suspended for 1 year. That suspension has been stayed. Probation for 2 years effective September 23rd with a $2,000 penalty. And they have to hire a consultant to provide regular reports to DOH. And I just want to mention that New York City REMSCO, we spent over 2 years trying to help them. But Bensonhurst refused all our help and guidance, and it has come to this. And now they can hire somebody to help them. And for everyone's information, if you ever need to see enforcement actions for either providers or agencies, I'm going to be sending you a link to the DOH website, which will tell you everybody and every agency that has any issues with the Department of Health. With regards to ambulance agencies, we are getting communications between the New York State Volunteer Ambulance Association for Districts 4 and 18 and Bedford-Stuyvesant VAC, who is being helped by representatives from the volunteer community. They also are suspended by Department of Health. And so far it seems to be working. They're working together. We also submitted a letter on behalf of Central Park Medical Unit, confirming that the Corps was activated under mutual aid from March 29 to May 31st. I believe that they're trying to get some kind of reimbursement from FEMA. We received an email from RTAC, and I saw that Dr. Simons is here, so he'll be able to speak at REMAC. Requesting REMAC discuss the transport of traumatic cardiac arrest patients to trauma centers, even if it means bypassing closer facilities. And you're going to be talking about that at REMAC. We received a letter from Mercy Medical Center at Rockville Center and St. Joseph's Hospital asking to be listed as primary stroke centers, and I think Dr. Bonelli can respond to that later. We sent out agendas and minutes and also a REMAC advisory regarding REMAC paramedic credentialing. And that's it.
Cool. Okay, so let's move on to the subcommittee reports. We'll start with CNC, Paul.
Good evening, everyone. Certification and Credentialing Committee met on October 2nd and October 16th virtually. The focus of the meeting was essentially a line-by-line item review of the existing questions in the exam as the exams are continuing to proceed. And essentially it's like almost like that, the millennium having to turn over all the data to 4-digit years. We're just removing all the protocol references. A lot of the questions say things like according to protocol 505C, and essentially prepping them for the unified launch on January 1st. For those of you on the call who have any concerns about the exam, it was brought up to me by multiple parties in the last week about the concern for what protocols to study. The official word is that the protocols test what are the protocols. The test tests the protocols that are active the day you take the test. We can't say take the test and plan for the protocols that are going to be live in 3 months. But it's been a painstaking amount of work, which is why we actually doubled the meetings up this month to get up to speed. None of the conflicting information between the protocols is tested, so as far as we can tell. And we've been using this test for several months without any jumps in the failure rate nor complaints from people who failed based on a stipulation that's between the existing and the unifieds. So the test is testing essentially the unified protocols with what we're using in the current, what's currently available. So it's almost a double, it's really working on multiple cylinders. That's basically it, but we'll have data on the exam after the unifieds go live because it's too much of a moving target at this point. Any questions?
Okay, any discussion? Okay, very good. So Dr. Lai, let's move on to the protocol committee report. There's one protocol that's going to be brought as a second motion from the protocol committee. So please go ahead.
Sure, thank you. So the protocol committee met on 9/25 and then 10/9. So just as a quick intro, so just in addition to reviewing and putting forth new protocols as needed to REMAC, the protocol committee has been tasked with reviewing the unified protocols to pay particular attention to the ALS content for these, and then comparing and hoping and with the goal of updating them to kind of see how they are, how similar they are with the state ALS collaborative protocols that came out in August of 2019. In order to do this, we will hopefully be able to present some protocols at each REMAC meeting with the overall goal of updating all of the protocols, appendices, and the GOP sections in time for the summer CMAC session so that we can get these all approved. Hopefully that's going to be our overall goal for that. So to start off with our first protocol that we would like to present from the protocol committee that was originally submitted by Matt Friedman and a few others from MIMO is a generalized pain management protocol. And Joe, I don't know if maybe you can kind of put this up when we kind of go through for discussion. Essentially, so this is a protocol that does have a counterpart in the state ALS collaborative protocol. Well, hopefully Joe Raneri will put this up soon, hopefully.
Joe or Marie,
anyway,
can we pull up the pain management protocol? That would be very, very helpful. Put it like share screen.
Only Marie can share screen right now.
Okay, Pam, do you want me to make you the host? Or hold on.
It should just be whatever that was sent out, Marie. So, I mean, you can definitely just share that document and then we'll kind of walk through it.
Okay,
if that
just
makes
give
it
me
easier.
Give me a second to.
No problem. So I'll just kind of just start rambling then. So this is a general pain management protocol. So this is different than what we have traditionally used in this region. We have traditionally used the isolated extremity injury in order for our providers to be able to give pain management that is sort of under like standing orders for the pain. Thank you very much. So I just want to just go through some of the highlights in terms of like some of the big major things to kind of discuss, and then kind of can then open it up for discussion as you see, David. But big changes in terms of what we see in terms of the available options that are available. For option A, morphine 0.1 milligrams per kilogram IV/IM, up to a maximum of 10 milligrams may be given for those with an appropriate systolic blood pressure. So that is different than what we have currently been using. The fentanyl, I believe, is the same than what we have had in our unified protocols. The other two new additions that we do have in our protocol currently right now is a option C, which is ketorolac, 10 milligrams IV and IM for adult patients only. Along with that, as an option that providers may also be able to administer an opioid analgesic if the pain is not relieved under standing orders. So that's either option A or option B. Option D is also new to our unified protocols, in that acetaminophen, 15 milligrams per kilogram PO may be given to pediatric patients only. Medical control options, we have repeat dosing of the above opioid analgesics that are similar to what we have had done before. The new addition here is going to be ketamine, 0.3 milligrams per kilogram IV or 1 milligram per kilogram IM-IN. This is similar but not exact to what the state collaborative protocols currently have. The state collaborative protocols currently have they have a standing order ketamine 25 milligram IV dose, as well as a dose range for the ketamine IV to be given for that. So I think that this was something that the protocol committee had discussed, that we would like to keep things to not be dose ranges to try and eliminate any sort of ambiguity for our providers, and just to give them one dose that's there. And then just the last part is just some of the key points and considerations for our providers for this protocol. A lot of what was originally in the state protocol, after much discussion, will be kind of rolled into like a GOP section to kind of to try and eliminate a lot of repetitiveness that would be sort of ongoing throughout some of the other future protocols as well. So David, I believe that these are the major things, and if you want to open it for discussion.
Just to point out, this is Joe Raneri. We have a couple of questions that are listed in the chat. One from Nathan Reisman, key point. One, hemodynamically unstable should be hemodynamic instability. That sounds like a suggestion. And then Jason Zimmerman had a question: after giving Teradol, in what time frame can they consider giving an opioid?
So even like right now, I think that we did leave it open, and we would leave that up to the providers. As you all know, I mean, for those of us who do use Toradol or ketorolac in the in our hospital jobs, the onset pretty much can vary between about 15 to like 20 minutes or so. So I think that we have left that open there, but I'm open to discussion. But I think that we're open to make any sort of additions or modifications to the protocol as we decide in REMAC today.
Okay, I think at this point, I know that Robert Ackerman also put something in the chat, but at this point, why don't we just verbalize it for everyone, because I don't think everyone is following the chats, and just have verbal comments. So let me go through these all. Okay, so yeah, so Robert Ackerman is asking, are there any concerns about infection control for Tylenol PO?
Yeah, just because most come in multi-dose vials. Are there going to be any recommendations to use a single-dose vial?
We're not saying how to give it, Robert. We're not saying how to give it, nor would I say the time frame either. I mean, the protocols are there as guidelines, not there to be a rigid one-size-fits-all.
Okay, guys, let's please stop with the chats, and let's please have an open discussion so everyone can read and talk and answer. Okay, Jason Zimmerman recommends individual Tylenol packages.
I recommend it's an option, David. I mean, right, but as Paul said, we don't have to give that recommendation. Whichever agency is putting it on as an option will have their own infection control standard to how they want to do it. Tylenol does come in the individual packets, and like everything else we do, that's going to be up to an individual agency and director.
Okay, I think that's an appropriate answer, but is there any further discussion about this?
Yeah, Hey, Dave, it's Doug. I'm sorry, I put the raised hand, so I don't know how we're gonna move forward for discussion, if we're raising the hand or not. I know
It's hard
this
for
may
me to
not
see
be.
if everyone's raising hand. There are too many people raising hands.
Well,
Paul is raising hands. Nathan is raising
oh,
hands. Okay.
all right.
Only
So,
Marie.
I'll just,
Well, we have two people with their hands raised. One is Doug Isaacs and one is Nathan Reisman.
Oh, wait,
So let's. Oh yeah, and yeah, Robert Leviton is also waving. So Robert, we'll talk about your. We'll get in 1 minute. I just want to talk about this Tylenol issue specifically.
So
Okay.
a couple things. One, we don't really recommend how people supply it, but stepping back, I know this may not be popular. I personally don't think this tunnel should be in this protocol. You know, this is would be formaldehyde. Right now we splint, we ice. It's just another thing for medics to carry, and just adding to the protocol. I know this is basic stuff we do in the emergency department, but we have to think about the field. It's also weight-based, so it's not going to be pill, right? If this were pediatrics, I assume this is going to have to be a liquid as opposed to a pill. And again, while I understand this is standard of care in the emergency department, I don't believe personally, I know it's not popular, that this should be in the protocol. We have protocols for severe pain, which we want to treat, but for some formaldehyde, I do not think it should be in here.
Okay, Nathan, you raise your hand.
Yeah, my question is if we're going to make this if available and approved, or whether we're mandating it, because I think I agree with Doug that, you know, I'm okay with having Tylenol on the protocol, but I wouldn't, if I was in charge, I probably wouldn't have my medics be giving it. So my question is this going to be if available and approved like we've done in the past when some agencies want something and some don't?
So on the number 8 line, it says administer one of the following as available.
Okay.
That addresses that.
Okay, so I only need one of them. So as long as I have one of those options, I'm in compliance.
That's my understanding.
Okay.
Yeah, I believe so.
Yeah.
And then I agree with that. And I think, you know, to Doug's point, if we don't want to put it on as an agency, we can just not use it.
Okay, Nathan. No, Nathan talked. Joe, sorry. Joe, you wanted to raise your hand?
I was just wondering what the rationale was in adding Tylenol. I mean, in terms of in the pre-hospital setting, are you going to get significant relief with Tylenol? Not really. You know, if you're doing a weight-based dose, there is the chance that a medic could mess up that dosing and give Tylenol in a much higher dose than is appropriate. I just was wondering what the rationale was.
Pam, do you want to answer? Do you want me to answer?
I can speak to that.
Go ahead, Paul.
Right,
Okay.
Pam?
Okay. Sure.
Really, the rationale was if we're going to be treating pain, treat it. You know, we see a lot of, we wanted to have something that was an alternative, that was a non-opioid analgesic. We go into great lengths here to bring ketorolac and ketamine in for pain control. And if it's in the state formulary, I'm trying to pull up the collaborative protocols right now and see if it's there, but I'm pretty sure it is.
It is there.
Yeah. So, I mean, I don't think the protocols are meant to mandate what people carry, and protocols are meant for good medicine. And we're talking about an over-the-counter medicine. We're talking about, you know, something that's safe in the population we've chosen. We, you know, specifically says nothing about, you know, adults or potential liver failure, things like that. I mean, we wasted 90 minutes in the protocol committee on this Tylenol thing, and if it's it impairs our ability to move forward with other protocols. As it's written, there's no reason why an agency that wants to give Tylenol should be withheld from doing it because of other people having concern about it. As it says, it doesn't say you have to carry it. And what if an agency does want to? I mean, it's a simple thing to take care of a patient that is otherwise might get nothing. And if anyone has kids, you know, putting an ice pack on something really, I don't know. I mean, I think it's a bad look. I think it helps us look like part of the healthcare system. I think it helps us look like people that are providing care.
If you're going to add acetaminophen as a PO option, what about ibuprofen? Was that thought through? I'm just curious.
I don't
I
have
think
a
we
problem.
stuck, there shouldn't be a problem, above 6 months, but I think we stuck to the state protocol with that.
Okay.
With that
I'm just listen. I'm not saying that anything's wrong. I'm just asking the question.
I don't think ibuprofen is on the state formula. On the state protocols. Only Toradol was introduced.
It's on adult. It's for adult fever.
For Toradol.
Yeah,
correct?
so
No,
ibuprofen is listed as an option, as an oral option to be taken in the
Fever.
state. But I believe
And pain management.
right. But I believe that people were thinking that the non-opioid equivalent would be ketorolac.
Okay, Pesach, you have your hand raised as well.
Yeah, and just in this regard with the Tylenol and the ibuprofen, I noticed that the line at the top of the protocol that said that this is for severe pain management has been removed. Is the idea that this can now be used for mild or to moderate pain as well, using that Tylenol option? And does that open us up to the possibility of the Toradol and and the narcotics being used for mild to moderate pain? Or was that an oversight?
So this is our general pain management protocol. I think that, in terms of like what the region believes that what we should be doing for that. That's why it was kind of like kept open because of the inclusion for the acetaminophen. So that's why the semantics like that was removed.
Okay, Art, you have your hand raised. Art Cooper.
Unmute. Yeah, I do. I would tend to side with those who see this as a severe pain protocol rather than an any pain protocol. I don't have a strong objection to acetaminophen in pediatric patients, obviously, but the onset of action is going to be slow enough that unless we're talking, significant transport delay or what have you, you're probably not going to get the benefit from it soon enough to make a huge difference in pain in the pediatric patient. Plus, if we're talking severe pain, acetaminophen is not going to really touch it. So I don't feel terribly strongly about it, but and if people want to leave it in, I certainly won't disagree. But I think that the value added here is pretty minimal, and would suggest that it not be included. Thank you.
Art, you know that the flip to that is we also give steroids in the pre-hospital setting for asthma when we know that won't benefit during our transport. John Berkowitz.
Yes, that is true. Yeah, I understand that. But at the same time, I think they're two very different medications for two very different indications. Thank you.
Just a quick question on the ketorolac dose at 10 IVIM. That seems a little low, especially as an IM dose, to do much good. What are your thoughts on anyone's thoughts on the dosing?
Yeah, so John, we actually took a look at a lot of the literature that was surrounding this.
I took the number from the online. How are you today?
I'm sorry, but I'm on a conference call right now. You're going to have to call back during regular.
Marie, mute yourself. Okay, here we go.
Okay, so we there's actually like quite a few articles for both IV and IM that I can most definitely share with you, John, if you are interested for it. But it does look like that in terms of like a therapeutic dose for ketamine, both for IV and IM, 10 milligrams is what has been reported in a few different sources on there, including randomized controlled trials.
Okay, Ben Zabar.
You meant Toradol, not ketamine, right?
Yeah, ketorolac, not ketamine.
Ketorolac, yeah, sorry.
Yes, yes.
Okay, got it.
Toradol. Ben Zabar, then Paul Barber.
Hey, just a quick question. I apologize. Can you just remind me, is this going to replace the pain management in an isolated extremity, or are we leaving isolated extremity? Because if this is going to replace the pain management in that, go ahead.
So this is going to be like a general pain management protocol so that providers would be able to use this for whenever a patient is going to be with instances of pain. And this is going to be to hopefully eliminate a lot of the repetition that we see with a lot of our current protocols. At least that's what I believe that the aim was supposed to be. So,
Okay, so then
if I'm wrong.
in that case, I would suggest then key points considerations under 3, where it says injuries with a risk of bleeding, it says with a risk of bleeding or suspected fracture. Because I think part of my concern when we were discussing it was giving NSAIDs for possible fractures, which I know ortho sometimes doesn't like. That's my suggestion.
So David, is that right? So, oh, I was just going to say,
sorry,
so
go
I
ahead.
mean, it sounds like from a lot of what we're hearing from the REMAC discussion today, that it sounds like that a lot of people would like to remove option D, the acetaminophen for the pediatric patients. Is that what I'm kind of gathering?
I don't know.
No?
I disagree. That's not what I hear.
Okay.
I think there was a question.
Okay.
I think Ben was questioning about NSAIDs. I don't think he was questioning about
So there
Tylenol.
has been no motion.
That's what I was going to say. There's a motion. You need a motion. Sorry.
There's been no
Yeah.
motion to change anything. The seconded motion coming from protocol is a valid to vote on. If you have to make another motion to make a change, and there hasn't been one.
Okay, Nick. Okay, I want to
Robert
try
has his hand
to.
up.
Okay, gentlemen, ladies and gentlemen, I want to try to end this discussion at some point. So there are a couple of people with their hands raised, and then we'll probably have to move forward. So Nick, go ahead.
Oh, I'm sorry, David, just a point of order.
Robert, just so you know.
Just a lot of our programs don't have the raise hand option. So if you see someone, our raise
I'm sorry.
hands in our pictures, in our.
Okay, Brad, I can't see everything. I do see the raise hand in the program. I don't see it. Okay,
It doesn't have, a lot of programs don't have that.
Okay, Brad, why don't you, so go ahead, Brad. I imagine.
No, I wasn't trying to jump the line. I just wanted to let you know.
Cool. Okay,
But
Nick,
I was going to
go
say,
ahead.
the fentanyl.
How about this? Does this work?
Well,
I noticed
Nick,
the fentanyl dose, we used to have a max of 100 with a repeat of up to 100. It seems like now we've lost that max of 100. So theoretically, someone who's 200, I guess, kilograms would get a 200 microgram dose at once. Was that on purpose to take out the max of 100 micrograms?
Oh, I'm sorry. I think that might have been an accidental omission. I'm sorry about that.
Okay, I'm gonna run, Nick, you're next.
Great. Thanks. There was a lot of debate there. That was good. One of my questions was going to be the fentanyl that Brad brought up as a 100 microgram limit. So I think we can take care of that. But then again, on that same point, it also says that they can go ahead and give a second dose every 5 minutes until they reach a maximum of 200 micrograms, which in my impression, I think is a pretty hefty dose, but we can discuss that after. My main points and my issues are, I like the introduction of this protocol. I really do. I just have concerns of how we may be introducing this, and I'm just looking at it from a system point of view and a telemetry point of view and our crew members' point of view. And these are my issues. Just to start off, I think the morphine and the fentanyl, I don't disagree with them, but I don't think they should be standing orders. I think they should be medical control options for a couple of reasons. I think it's a good idea. No, I said this before, and I sent my notes into protocol committee. But my issues are these. My issues are, it's a good idea for the medics in some situations that they're in where they might be strong-armed or feel that they have to give the medications to give it. And I think it's easier if they are able to give it under the supervision of a physician. So this way, the burden is taken off of them if they're in circumstances where they might feel that they're being, I don't want to say harassed, but urged to give the medication. So I think that gives them a little bit of an out if they're in a bad situation. The other thing is this is reminding me a lot and very similar to what the asthma protocol is. In the asthma protocol, a lot of asthmatics know they can call us for asthma treatments. We go there, we give them the treatments. Some of them ask for magnesium and Cytomedrol or Dex. And they even tell our crews sometimes, call your doctor, I don't have to go. Even though in many cases, we always say, well, if you're going to give these medications, you give them in transport, which doesn't happen most of the time. So I see this as a way for a problem, especially now in the opioid epidemic that we have, is that this could be something that people know it will get out, that we give medications and they administer the medications and then they go through an RMA process. And then not only are we not doing justice for these patients, we're not monitoring them like any other protocol. We say anytime we give medications, we monitor the patient. They're able to RMA, and who's to say that there may be some drug seeking along with this, or who's to say in the name of safety of our crews that now they know that this medication is out, they can give it standardly and put in calls and confront our medics for these drugs and medications during this epidemic. So in order, I think, to protect it or to control it a little bit more, I think it would be a great idea if we don't set the same similar example as we did with asthma and put it in, not that we shouldn't have the protocol. I agree with the protocol. I agree with having these medications. I just think that before they administer them, it takes 5 extra minutes to call telemetry. They can decide what the situation is, call telemetry and make that call with the telemetry doctor. And this way it can be given under a controlled situation safely and appropriately. And this way we don't have also this going around the city.
Understood, Nick.
And
Understood.
So that's my main call on this protocol.
Okay. I would like. I think that that's understood. Paul, Barbara. Then I want to Joe Schenker and Robert, and then I think we need to put a discussion to this. It's a great discussion, but I think a lot of this should happen in protocol, and I know a lot of this did. So Paul, Barbara, you're next.
That's what I wanted to say, David. Your ears must have been burning. This is a great conversation that should have been had at the protocol committee. I'd like to remind everyone on the call that this is a forwarded motion from a committee, and I think we should discuss motions or a vote. The protocol committee has a large list in front of them regarding updating the ALS protocols. This is, we do not need to make our fellow voters vote in majority. I think everyone wants to speak their point, but this is a forwarded motion. We should vote on it or we should amend it as needed because there's a lot of work to come from behind it. And that doesn't mean we should do things that are unsafe, but this is, most of this is already standing order. And what's not standing order is essentially from the state with maybe 1 or 2 pieces from the protocol writer. But there's actually a whole database of protocols that need to be revised, and we have a lot of work to do. So this is the type of conversation that should have been had Friday in the protocol committee meeting that there was 2 of them prior to this meeting. And the paucity of physician involvement on the committee is actually a detriment to those who were actually there working on it. That's my piece.
Okay, very good. So Robert, and then Doug, and then I'm gonna end this discussion and we'll vote on it. Go ahead, Robert.
So this is to Pamela and Paul. Just a simple thought. In the key points and considerations component of this, would it be possible to have a precaution statement? We all know that morphine is associated with histamine release and can lead to increased bronchospasm. And similarly, ketorolac is also associated with bronchospasm. So do we want to have a precaution statement as number 4, just alerting our team paramedics out there that when they use these medications, they should be aware of the potential for bronchospasm. And that would be the only addition I would suggest.
Pam?
If others agree that we should be including this on there, then I don't think that there would be any issues to include that as a key point or consideration.
Thank you very much.
Okay,
And
very good. So, sorry, go ahead.
You made a very
system relatively, and I didn't know that there was a protocol committee meeting where I could have brought this up sooner and not have to sit there and wave flags in my hand. So how do we get on invite for that for the future?
Well, let's take that offline, Robert. If you want to talk to Marie, she can give you the information about that.
Thanks very much,
Okay.
Joseph.
No problem.
Doug Isaacs, and then we're going to end this discussion. Go ahead.
Just 2 points. One is, I understand we discuss things at protocol, but we don't always agree at protocol. And the idea to discuss, I know we have to limit our conversations given the time, but the REMAC committee is for discussion. The other thing is with ketamine. Since protocol, I've been doing some research, and actually the bioavailability of ketamine we thought was similar to intranasal. It's actually similar to IV. So far, we've seen most articles and research show 92%. So I'm not for ketamine as for analgesia, because you really, if you can give it IV, IMIN, you have to carry 2 formulas, or members have to dilute it. And again, that's bringing emergency, the question is, do we need ketamine as a pain management? Again, I think we got to keep adding things. We're putting a lot on our paramedics. So those are my comments.
Okay, very good. So there's a second in motion from there's a second in motion from protocol to move forward with this protocol. I think unless I hear any other motions, I am going to bring this up for a vote now.
David, I just want to say one more thing.
Sure.
These comments were sent in. I don't know how much they were discussed, my comments and my concerns, but I don't know if other people have these same concerns. And I'd like to hear how that is, because if that is a concern that other people have, I think it's worth the time to go back to protocol and reassess this along with some of the changes that have been discussed on medications and doses. I understand everybody has a lot of work, but we shouldn't rush something through for the sake of getting it out. We should do it right.
I'd like to put forth a motion. I'd like to put forth a motion to send this back to the protocol meeting for relook at a couple of different things.
I'd like to.
Okay, go ahead, Joe.
David, I mean, this protocol has been in design and in its development since Mike passed away. It's been 3 years in the making. There is nothing under the standing orders that is not standing order today, other than the ketorolac and acetaminophen, which everybody would give without a question. I don't think there's any issues. If you're talking about the morphine and the fentanyl, that's standing order today for isolated extremity injury.
But only for isolated extremity issue, not for other injuries in general pain.
David.
That's all.
Okay.
So vote on calling the question, and if everybody agrees, then we vote on the protocol.
I'm sorry, there's a motion to refer.
No, there is not a motion. There is a motion that was not seconded.
Okay.
Would anyone like to second my motion to refer this back to protocol meeting, because there are a couple of issues that are still yet to be worked out.
So if you call the question, that stops the conversation. You need to vote on calling the question. Then if the vote on calling the question fails, somebody can second your motion.
Very good. Okay, who called the question? Did you call the question, Joe? Very good. So please, let's vote on calling the question.
It doesn't have to be seconded. We just have to vote.
I'm sorry. I want to understand this exactly how you're saying it's going. Please, Joe, repeat that.
It does have to be seconded, Joe.
I'm sorry?
Not calling the question.
Calling the question.
Calling the question requires an immediate vote on whether to call the question.
It still has to be seconded, I believe.
Once it's been
I second the call the question. I second
There
it.
you go.
Paul. There you go.
All right. In that case, we can vote. I don't know how you want to do this. That'll be the way.
I think we'll have to do this by name, by names, because we won't. It won't be orderly in any other way.
David, just explain. Just repeat how calling the question, what that vote really means.
So calling the question stops the discussion, and if there is a majority vote, we go immediately to voting on the motion on the table, which is the motion that came from protocol. So if there is a positive vote to call the question and people agree, and we vote on that in an affirmative, we immediately move to voting on the motion on the table, which is the seconded motion from protocol.
Okay, so Marie, let's start with a roll call vote because I don't see how we're going to do this in any other way that will actually get, accurate numbers.
Okay. Okay, so when I call your name, let me know if you vote in favor of calling the question. Okay. Paul Barbara,
In favor.
Cindy Basilios,
Yes, in favor.
Neil Cemalovic,
Yes.
Wallace Carter, Robert Krupe,
In favor.
Dr. Lee,
In favor.
Reed Caldwell,
In favor.
Jason Zimmerman,
Not in favor.
Jonathan Berkowitz,
In favor.
David Lobel, or David Eng,
In favor.
Jeffrey Rabrich, Michael Redlener.
In favor.
Okay. Dr. Schenker,
I think Dr. Roberts was on the call.
Yes, I said in favor. Didn't
oh, okay.
Oh, I didn't hear you.
I thought that was Dr. Redlener. Did Dr. Redlener vote? Is he here?
Yes, I'm here and I did vote.
Okay. Dr. Schenker?
Yeah, I'm in favor. Remember, this is just of calling the question. We're going to still have to vote on the actual motion.
Dr. Shalish? Oh, no, he was trying to get on. Nick Alexandru?
I am vote against.
Glennis Seda?
Not in favor.
David Benelli?
I'm going to abstain as the chairman.
Okay. Dr. Gonzalez? Dr. Isaacs?
Not in favor.
Brad Kaufman?
And not in favor of calling the question.
Dr. Cooper?
Not in favor.
Dr. Marshall?
In favor.
Kevin Munjal?
In favor.
Jessica Van Voorhees? I could have sworn she was here.
Against.
Against? Okay, just give me a second to count all these. Okay. Okay, 1, 2, 3. 1, 2, 3, 4, 5. Okay, so it's 12 in favor, 7 against. Do you hear me?
Okay, got it. So the motion passes to call. So I guess now we go and we vote on the protocol itself. Again, let's do a roll call. Let's do a roll call, please, for the pain management protocol. As is.
And this is just a quick clarification. So this is on what we have written down not the sort of additions that people talked about during the discussion. Is that correct? Just what's written down?
What is written down, I imagine that if there's like a type of correction, like, hemodynamic instability, I guess that's okay. I think that there was a comment about the bronchospasm issues. I don't think that's a problem to add it on as a key point.
Thank you.
Hello?
David, what about the max dose of fentanyl on initial administration?
I think that was also a typo more than anything.
Okay,
That was a
Right?
mistake, yes.
Yes.
What about
Okay.
doses of ketamine? The actual dose of ketamine, 0.3 IV.
I think that's a
That's
change that would have to be
a
voted
main
on.
objection of mine.
Okay, well, that was not something that we discussed. So at the moment, that was it. We're voting on, I think that those three little comments, which are really typo or edit errors or, points of information, I think that's fine. Anything else, we're not going to vote on right now. We're just going to vote on the protocol itself.
David, what about
Dave,
the
just-
Tylenol that was discussed as well?
I'm sorry?
The Tylenol that was discussed as well, is that in or not?
Tylenol is in. The Tylenol is in, it's in the protocol.
And Dave, just because the Academy is going to ask me that key points and considerations for ketorolac contraindications, things with risk of bleeding, if that includes fractures, suspected fractures or not. I don't know if that's a typo or we discussed it, but there was no motion.
I don't know that. I don't know. I honestly, I don't know that sometimes you give ketorolac for orthopedic fractures. I don't.
We spoke about that in the meeting, and we knew that the wording of fracture in light of the lack of x-ray vision on behalf of the crew members might be a little difficult. And I think we can leave it to their clinical judgment if they think someone has an injury that shouldn't get that type of NSAID. That's what training is for.
Guys, the calling the question means that we vote on what's in front of us.
Yes, we
Okay,
called.
so let's please begin.
Yes.
Yes. So let's please start the voting on the protocol. This is the medical standard call. We are still in medical standards. We still didn't finish that meeting.
Just making
And
sure.
I implore everyone to try to join the protocol committee meetings because this is becoming very difficult to handle. Okay, let's please start a roll call on the pain management protocol.
Okay, and this is we're voting on a motion to approve the protocol as it is written, sans the typo.
That's
correct?
right.
Okay.
That's right.
Oh my God, what did I just do? Oh, there it is. Okay, just please vote yes or no or abstain. Paul Barbara.
Yes.
Okay. Hold on, because I'm counting as we go. Cindy Basilios.
Yes.
Neil Cemalovic.
Yes.
Am I pronouncing your name correctly?
Yeah, pretty close. Thanks.
Okay, good. That's a problem I have.
It's okay.
Dr. Carter, Wally Carter. Dr. Lee.
Yes.
Reed Caldwell.
Yes.
Jason Zimmerman.
No.
Dr. Berkowitz.
Yes.
Marie, remember that this is medical standards. Non-physicians can vote as well.
Oh my God. David Eng.
No.
Jeff Rabridge.
Yes.
Michael Redlener.
Yes.
Dr. Schenker.
Yeah.
Dr. Shalish? Okay, Nick Alexandru,
No.
Glenn Asada,
Abstain.
David Benelli, you're
I'm the
abstaining?
chairman. Yes.
Okay. Dr. Gonzalez? Doug Isaacs?
No.
Okay. Bradley Kaufman?
No.
Annemarie Girgenti?
No.
Kevin Ward?
Yes.
Grace Cacciola?
No.
Madeline Fong? Maddie Fong? Sean Graves?
Sorry, I was muted.
That's
I'm a
okay.
no. I'm a
No?
No.
Okay. Sean Graves? Robert Ackerman?
Yes.
Okay. Morty Lax?
Yes.
Arthur Cooper?
No.
Eudigia Langsam? I'll give him a second, he just got in. Lou Marshall?
Yes.
I'm here.
Do you want to vote in favor of the pain protocol as it is written?
Me? No, I don't even know what it is. So
Okay, we'll have to. You just walked in, I can't blame him. Dr. Munjao?
yes.
Okay. And Jessica Van Voorhees?
Yes.
Okay. So it's 15-9, it passes.
Very good. Dr. Lai, is there any other items that are being brought from the protocol committee for discussion? To medical
No,
standards?
nothing else. Our next protocol meeting is on October 30th at 10 a.m. virtually. That Marie will be sending out a invite later on.
Thank you very much. Do we have any unfinished business? I don't believe so. Is there any new business to be brought for discussion? Okay, having here, I'm not seeing if anyone is raising their hand, so please raise your voice if there's any unfinished business or new business that you wish to bring up. Otherwise, I'm going to entertain a motion to adjourn. Is there any second one?
Second.
Very good. Okay, I don't think we need to vote on this as a roll call. Thank you very much, everyone. Again, these discussions must be held at more in depth, or can be held more in depth at protocol committee. Thank you, everyone. The next meeting, I believe, is on November 10th. I think we're gonna move the hour of both committees to coincide at the same time. So we'll be able to have a discussion only once about everything. That is just about it. Joe, the stage is yours.
Also, Dr. I did not send out the survey asking people if they wanted to meet earlier, like 3 or 4 o'clock. I'll send that out before our next meeting in November. So maybe we will be meeting
That'll be
all
great.
earlier.
Excellent. Thank you very much, everyone.
Marie, Dr. Salish is trying to get in and he says he can't get in.
All right, so let's let everybody in who's there.
I've let everybody in. I don't know why Dr. Shalish cannot get in. I've sent him the link
Okay.
Yeah, the
multiple
problem is he's probably
times.
trying to use the invite. The invite did not work for me.
Did anyone else have a problem with the invite? It's the same invite I've sent out every month.
No, the calendar notice. The calendar notice. The invite worked.
The calendar notice didn't work for me either.
Me too.
Okay, but the link in the invite worked, right?
So maybe he's using the calendar invite.
Okay, I'll try
The
again.
link in the email you sent today worked.
Okay, I did send that to him. I sent it to everybody. There's only so much I can do. Okay. I do not get this. Okay. Whenever you're ready, Dr. Schenker.
All right. Do you want to give people 5 minutes to see if anybody else joins us, or you just want to get going?
I think we should just get going, and Dr. Shalish finally joined. I'm going to make you the host.
All right. And then we have to do a roll call attendance.
Okay. Make host. And let me pull up my roll call attendance. Okay. Sorry, I didn't even have my camera on. Just give me a second. I'm bringing up the REMAC attendance. Okay, everyone, I'm going to go through a roll call attendance. Please let me know if you're here. Robert Winchell.
Here, just take a minute to get off mute.
That's okay. Dr. Schenker is here. Robert Ackerman, still here?
Still here.
Okay. Nick Alexandru, still here. Eric Cohen, are you here?
I'm here, yes.
Okay. Kevin Munjal?
I am here.
Thank you. Cindy Basilios?
Here.
Grace Cacciola?
I'm here, sorry.
That's okay. Dario Gonzalez? I'll take that as a yes. Dr. Aceda?
Here.
Brad Kaufman?
Here.
Doug Isaacs?
Here.
Nathan Reisman?
Reisman.
You know, I'll forget it by the next meeting. Kevin Ward?
Here.
Annemarie Girgenti?
Here.
Hi, am I pronouncing your last name correctly, Girgenti?
Yes, you are. Perfect.
Wow, at least somebody likes what I
Yeah.
say. Okay. Allison Burke? I know Allison was on before. And Samia McEachin? Jeffrey Rabridge?
Here.
Reed Caldwell?
Here.
Jonathan Berkowitz?
Here.
Lewis Marshall?
Here.
Michael Redlener?
Present.
Laura Ivacoli?
I think she couldn't make it.
Stuart Kessler? I thought Dr. Kessler was on before. Okay, Matthew Fink, Wally Carter.
Marie, you can't really assume anyone who was on before is still here. That's not legal.
Well, I'm not writing that they're here,
Okay.
so.
And I'm present. They don't say present, then they're not here legally.
Yeah, I'm not writing down the present if I don't hear them answer. Wallace Carter? Okay, I guess people left. Dominic Battinelli? Efren Rendon? Peter Wire?
Here.
Was that Peter?
Yes.
Thank you. Paul Barbara?
Still here.
David Benelli still here?
Very much here.
Sorry, David. Celia Quinn? Tim Stiles? Mark Cantor?
Here.
Sharice Berry? Joseph Bove? Sean Graves? And Allison is here. She doesn't know how to unmute her line. Sorry, Allison. I'll help you in a second. Sean, are you here? William Fisher?
Here.
Robert Krupe?
Here.
Jessica Van Voorhees?
Yes, I'm here.
Art Cooper?
I'm here.
Yadidja Langsam?
Present.
Tony Shalish?
Here.
And Christopher Sorrentino? And I believe Dr. Simons is here from RTAC. Dr. Simon, you here?
He's still on screen.
I'm here. Just took me a minute to figure out how to unmute.
That's okay. That's why I give you a few minutes. Okay, have I gotten everybody? Is there anyone else here that's a guest that I need to?
Did you get me?
Who is me?
Oh, sorry, Maddie.
Okay, Maddie, thank you.
Lauren Kosterko still here.
Okay.
Josh Bucklan.
Hi, Josh.
Hi.
Matt Lindner.
Matt
Hey,
Linder.
Seth Zirkin.
I'm sorry, who was that?
Pesach.
Hey, Pesach. Okay.
John Washko.
Hi, John.
Jim Downey.
Dave Prezant.
Hello, Dr. Prezant. Okay. Anyone else?
Annemarie, it's Morty. I'm still here.
Okay. Okay. Someone's got a cat?
A hungry
Me.
cat or
Yeah, it's me. I got two of them.
Oh my goodness. Okay, so my attendance is done. We have a quorum and we can go forward.
Marie. All right, let's start with the correspondent. Actually, approval of the minutes from September 15th. Has anybody had an opportunity to read them? I hope you all have. And if anybody has any questions or concerns or comments, please speak now. If not, I will entertain a motion to approve the minutes. All right, Anthony, I see you moving your hand. You might be just adjusting your computer, but I'll take that as a motion. All right. And Madeline, you just laughed, so that's another one. All right, so the minutes from September 15th are approved. The correspondence report, Marie. You're muted, Marie. Marie, you're on mute.
Sorry, I'm getting it.
All
Damn
right,
mute.
correspondence report.
Okay, hold on, I'm getting it. Come on. No. Open up. Okay. Membership, no new information. Fire Department EMS, no new information. New York State DOH, statement of charges from the New York State DOH against Bensonhurst VAC. They're suspended for 1 year. That suspension is stayed and they're on probation for 2 years effective September 23rd with a $2,000 penalty. They must hire a consultant and provide regular reports to Department of Health. Just for your information, New York City REMSCO spent over 2 years attempting to assist, but Bensonhurst leadership refused guidance, and now they're gonna have to hire somebody to help them out. If you are interested in looking at enforcement actions throughout New York State for both providers and agencies, I am sending a link to the New York State webpage for their EMS disciplinary actions and enforcements. This way you can look and see, personnel or agencies who are having enforcement actions. Ambulance agencies, we have regular communications between the New York State Volunteer Ambulance Association, District 4 and 18, and Bedford-Stuyvesant VAC. The volunteer sector is helping Bedford-Stuyvesant meet the requirements identified by the Department of Health with their own suspension. And they are helping them at this time, and we'll give you more information at the next meeting. We sent a letter on behalf of Central Park Medical Unit confirming that the Corps was activated under a mutual aid request from FDNY through REMSCO and participated in mutual aid from March 29th to May 31st. This was mutual aid secondary to COVID-19. I believe they're trying to get some kind of reimbursement from FEMA. We also received an email from RTAC requesting REMAC discuss transport of traumatic cardiac arrest patients to trauma centers. And Dr. Simons is here. He will be able to give you more information on this. We also received a letter from Mercy Medical Center and Rockville Center and St. Joseph Hospital Bethpage asking to be listed as primary stroke centers in our protocols. I'm not sure that either one of these hospitals is anywhere close enough to be in our protocols, but I'll leave that up to Dr. Schenker to discuss. We also sent out one new advisory, 2020-16. It's about paramedic credentialing. And I wanted to let everyone know that the state is behind on sending out new cards, and we are also not sending out cards as quickly as we would like, the credentialing cards. So we have listed on our webpage all the paramedics in New York City with their new extended credentialing date. And we're asking that agencies accept the temporary memos that we're printing for our paramedics, because many do not have cards. And that's the end of the protocol of the correspondence report.
Thank you, Marie. Does anybody have any questions about that correspondence report?
I have a question.
Yeah, you did. You go ahead.
Marie, the location on the web page is a little hard to find. I was searching for it with someone who actually needed it, and we spent quite a lot of time. Can you ask whoever designs the web page? This is probably important enough it should be on the front page, the link, rather than buried somewhere deep.
Yeah, I don't know why it is where it is. And that's why I sent out the advisory with the direct link. Right now I'm having some work done on the web page, and we're trying to move things around.
Thank you.
But right now, if they have a problem, they should just go to the REMAC advisories and go right to the advisory. It'll give you the link right there.
Right, but it's a member, who wants to know what was his status, and he didn't know to do all that. So that's why it needs to be on the front page. Okay.
Yeah, I agree.
Okay, thank you. As far as the discussion about trauma, I will hold that to the RTAC report. And then finally, the two centers requesting to be part of the list in the appendix as far as primary and thrombectomy capable centers are not primary 911 receiving hospitals. Is that correct, David? They're not in our local area.
That is correct. They're not 911 receiving centers. They are not considered also STEMI centers. They're not considered LVO centers. They're both for STEMI and LVO. There will always be closer destinations and more appropriate to bring to
My
the
point is
patients.
that even if they are those state certified centers, either thrombectomy or primary, they are not 911 receiving centers for the New York City region, and that is why they're not listed in that appendix. Okay, so we can forward that to the respective hospitals and explain it to them as such. Okay, any other questions about the correspondence report? I see no virtual hands up and I see nobody calling out on the screen. So I will move to the executive committee sub-report. There was no executive committee meeting since our last meeting. Again, so next we'll move to medical standards. Now, just to get everybody up to speed, there was a lot of discussion at medical standards. We can continue that discussion. I'd like to focus the discussion not on the operational issues for a particular agency, but rather on the medical issues, because this is a medical protocol. So if we agree with the medicine, that's one thing. If there are operational questions, that would be agency specific. But I think we can forward. So David, if you want to take away the medical standards discussion.
Sure. So the medical standards met just before this meeting. We will, Marie, can you bring up the protocol? There's one action item that's vote for vote at REMAC.
Yeah, I'm bringing it up.
You can't, Marie. I have to do it, but I got
okay.
it.
Oh, Joe, you do it. Okay. So as a result of work at the protocol committee, the a general pain management protocol was brought for approval at medical standards and was approved and moved forward to REMAC. I'm going to ask Dr. Lai to describe, give the highlights of this pain management protocol. Pam?
Sure. So this is a general pain management protocol. There are a lot of salient features that are similar to the collaborative ALS state protocols from August of 2019, but I just want to go through some of the highlights, especially for those things that are that differ from what we are all used to in terms of of what our protocols are currently, as well as what was previously in the unified regional protocols for here. Going down to the paramedic section. So this is a generalized pain management protocol. This can be used in any instance for a patient who has any pain and is not relegated to only an isolated extremity injury. So the big changes starting from the paramedic level are going to be to administer one of the following as available. So option A, morphine 0.1 milligrams per kilogram IV-IM. With a maximum dose of 10 milligrams. This is the same with the same systolic blood pressure limits that have always been there before. However, this differs from what we currently have with the initial max dose of 5 and then a repeat of 5 up to a cumulative maximum dose of 10. So this is different right now. The option B, fentanyl 1 microgram. Oh, I'm sorry.
Pam, just if there are any typos that we corrected, if you can just
yes,
comment about them too.
That's what I was gonna go through. Thank you for reminding me, David. So option B, fentanyl 1 microgram per kilogram IV-IM-IN. There is supposed to be a maximum initial dose of 100 micrograms, and then with the repeat dose to a maximum cumulative dose of 200 micrograms. So that is the language from our current unified protocols. New options that are available for us in the region that are being proposed is ketorolac 10 milligrams IV-IM for adult patients only. Also understanding orders is that if a patient has continued pain after the administration of ketorolac, that the provider may consider administration of one of the opioid analgesic options as above. So that would be option A or option B. Option D is also new to our protocol, where we would have acetaminophen 15 milligrams per kilogram PO. This will be relegated to pediatric patients only. Medical control options would be additional dosing of the opioid analgesics, option A or option B, with the morphine and the fentanyl, same dosing. Another medication that is new to our protocols right now is the ketamine 0.3 milligrams per kilogram IV or 1 milligram per kilogram IM/IN. There are some other key points and considerations that are there that include those for ketorolac, as well as for consideration for contacting online medical control prior to the administration of pain medications. There are a lot of things that have been omitted from this key point and consideration section that are from the state protocols that it was discussed in the protocol committee that these would be moved into the GOP section to remove some of the repetitiveness of our current protocols.
Okay, so this is the only action item that's being brought forward, and I guess now we can open it for discussion. Thank you, Pam.
All right, so I asked the people if you can use the virtual hand raising. I asked that you do that. If you cannot, if you can start speaking, and I will call on you. I will stop you if you're going over anybody. All right, Nick Alexander, you had your hand up first.
Yeah, I just want to restate my concerns about this protocol. I know I said them before, but there might be new people here. And although I agree with having a generalized pain management protocol, I disagree in how we may be going about it. Specifically, option A and B, which is morphine and fentanyl, is a standing order. I feel that these medications should be under medical control option. And I feel that these should be given when consulting online medical control for better judgment and better oversight, both for the medics and for the families that are there. So the burden is taken off the paramedics in case they're in a situation that's difficult. I also feel that during this opioid crisis may increase our calls for pain medication. And I think we may run into the same problems as asthma, where they call, they get treatments, and then they RMA. Even though on the bottom it says it should be done during motion, we know even with asthmatics take their medications, they sit there, and then they decide later, they even tell the crews, call your doctor, I don't have to go. I think this is a difficult situation for all of us to be put in. I think we may get, with the opioid crisis, we may, people may know we carry opioids and drugs, and I think that could put our crews in danger if they don't know that it's unless they know it's controlled by an oversight. And that's my main concerns for that.
Thank you. Doug, you were next.
Great. Thank you, Joe. Just two comments. I'll just reiterate one about the acetaminophen. It's for mild analgesia. I don't think we should have in the protocols. It's nothing for the medics to remember. It's going to be weight-based based on liquid. It's just another thing for them to carry for mild analgesia. I do not think it's necessary. We have other options. The other thing I want to bring up is the ketamine. I'm a little concerned about the dosing. I was kind of misinformed. I was looking at the bioavailability ketamine for IM. PASOC asked a question on protocol committee, and it was a good question. So researching it, I thought the bioavailability for ketamine was similar to intranasal, which is about 40 to 50%. But looking at a lot of the literature, it's actually closer to IV, 92%. So I've been speaking to some clinical pharmacists as well as some tox folks. So there's some active discussion. Later on, I'd like to, we'll make a motion to discuss that protocol, but I think we need to rethink again, I'm not for ketamine in this protocol because, by the way, if you're going to give it different routes, you're going to have to either carry two different formulas or you carry one formula, like 50 milligrams per ml that we do for rescue, but then you have to start diluting it if you're going to give it IV. So, and I think it's just an ER type medication. I don't think for our system, we should put in for analgesia.
Okay.
With ketamine.
All right, Paul, you're next.
Thank you, Joe. I'd like to just remind the committee here that many of these medications are already standing order. And if we remove them and make them medical control options, we're basically taking medicine that's in their hands and taking it out. I agree with Doug about the ketamine dose, though. I think that's an excessive dose of ketamine.
Okay, thank you. Jess, you're next.
The only thing I was going to say is that the addition that was made in the key points and considerations about bronchospasm with these drugs, I feel is a teaching point and just clutters up the protocol. So I think it may not be necessary. We already tried to declutter the key points and protocols from the state collaborative version. So that was my feeling about that.
Okay, thank you. Pesach, you're next.
I just wanted to support what Doug is saying. I know I don't have the ability to make a motion here, but hopefully someone can. When we originally drafted this, we drafted it with the dose being the same
Pesach,
for.
you actually do have the ability to make a motion. You just don't have the ability to vote.
Oh, well then, in that case, I'd like to put forward that the intranasal dose of ketamine be identical to the intravenous dose as listed. That's how we
So
originally drafted it.
I would ask that if anybody is considering making a change to the protocol, I will say right now, we're not going to do that here at REMAC. If you'd like to motion to send it back to protocol for some fine tuning, that can be done, but we are not going to discuss and change the protocol here. There's a protocol committee for that works very hard, and I think that it's important to do that.
In that case, I'd like to ask for this to go back to protocol committee for a little bit of fine tuning. And I say that with the support of Dr. Friedman, who helped draft this protocol.
Okay, so is there a second for that motion?
Second the motion.
Okay, so there's a motion on the table now to bring it back to protocol to adjust some of these questions. Nick, you had your hand up, and then I guess you took it down. And Matt Friedman, you have your hand up right now.
Yeah, hi. So at the protocol meeting, I missed the part of the conversation where the doses were being discussed. And as Dr. Isaacs alluded to, we are clearly will throw some people into a dissociated state at 0.3 milligrams per kilogram IV. There's a reason why the state has it as a range from 0.1 to 0.3. I think if we give everyone 0.3, some people are going to be dissociated, and I think we're going too far with that. The same for intranasal, we're overshooting and causing dissociated. So there seems to be a lot of discrepancy by the doses, and I think it needs to be further discussed.
Okay, thank you. Nick.
Yes, I agree that I think the protocol, I think this should go back to protocol for reevaluation. And I also just want to mention that the standing protocol, the standard orders that we have are for isolated extremity. They are not in other protocols. This is a general pain medication protocol, so it applies everywhere. I just wanted to correct that.
Okay, thank you. Paul Barber, you have your hand up.
Just to clarify the point about the dosing range, for those that weren't at the meeting, that was felt to be unique and novel to any protocol we've ever written, and was felt to sit on a single dose, because we have no other protocol that allows for dose ranges. If that's the case, then I would question why the medication's even in the protocol if it's so has such a high therapeutic or low therapeutic index.
Yeah, Paul, you're breaking up a little bit. I'm sorry. Okay, there is a motion currently on the table. Doug, you have your hand up. I'm sorry. Go ahead.
I'm sorry, motion, I just going to answer, if it's okay, Paul's question. I don't want to take everyone's time up. Again, the intranasal is about 40 to 50%, where intramuscular is closer to IV at 92%. So I think, we'll see what the motion goes. If we go to protocol, I can supply the articles.
I'm sorry if I wasn't heard. What I was trying to say was there was a dosing range that was brought up in the protocol committee, and that was felt to be unique and had never been done before. So that was set on a single dose. But if the drug has such a narrow therapeutic index, perhaps it doesn't belong in our protocols.
Sure. Art Cooper wanted to raise his hand, but he can't. So I'll raise his hand for him. Art?
Thank you, Joe. All I wanted to do was support the comments that Nick Alexandru made. And I would therefore be in favor, as others are, of asking protocol to reconsider this protocol. Thank you.
Okay, thank you, everybody. All right, at this point, so we have a motion on the table that needs to be voted on to send this back to protocol for some fine tuning. We've had a significant discussion, so Marie, if we could vote on that.
You do?
I'm gonna leave the protocol up for the vote, everybody.
So I'm sorry, this is to go back to protocol or this is to
Correct.
voting it in?
No, this is to send it back to protocol. That is the current motion on the table.
Okay. So this is to send the pain protocol back to protocol committee, yes, no, or abstain. Robert Winchell,
Yes.
oops. Dr. Schenker, I'll leave you for last. And this is only physicians voting. Nick Alexandru,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
okay. Dario Gonzalez, who I don't think is here. Let's get rid of that. Glenn Asada,
Yes.
Bradley Kaufman,
Yes.
Doug Isaacs,
Yes.
Nathan Reisman,
Yes.
Jeffrey Rabrich,
Yeah.
Reed Caldwell,
Yes.
Lewis Marshall,
No.
Michael Redlener,
I hate to
Michael
do
Re-
this. I hate to do this to the protocol committee, but yes.
okay. Well, it's their job. Laura Ivacoli,
Yes.
great. Wallace Carter,
Here. Jesus.
Wallace Carter,
Hadn't been here all day.
he was here before.
Oh, he was?
Yeah,
Huh.
okay.
All right.
Unless somebody answered and I thought it was him. Phooey. Sorry, okay. Peter Wire,
Yes.
Paul Barbara. Paul Barbara,
No, was on my meeting. No.
okay. David Benelli,
In favor of sending back to protocol.
okay.
That was my longest yes for record.
Celia Quinn and Tim Stiles are not here. Mark Cantor,
Yes, in favor.
okay. Dr. Bove is not here. And Dr. Fisher,
Yes.
Robert Krupe,
Yes.
Jessica Van Voorhees,
No.
Arthur Cooper,
Yes.
Okay, I think that's, and that's all our voting physicians. Thank you. And the motion passes 18-3.
Okay, thank you, everybody.
Okay,
Okay,
with that,
so-
that's the end of the medical standards report, I believe. There's no other action items. Next meeting of medical standards, as we mentioned, is on November 10th. Thank you very much, Joe.
All right, thank you. I'm just gonna stop sharing this and then see if I can share. If
The bylaws?
you give more sharing here. I can't. All right, so. One second. Hold on, I just gotta escape here. All right, let me just, I'm stuck here in a sharing screen. Here we go. All right, I'm gonna make Mike the host so he can present the QA data. Okay.
Joe, I'm going to start off giving the just general report, and then I'm going to go into the presentation. So the quality committee met on October 6th, and we just discussed a few key items, one of which I'm going to present in a minute. So I'm going to not talk about it right this minute. It's the First Watch program, the partnership for data quality and EMS data and quality that we're going to start to show and share a dashboard. And I'm just going to talk about that in a minute. The other item that we discussed was the REMAC and REMSCO after action report that is in draft phase. I hope it's currently at the quality committee level for review. I hope to have a draft of that out for the region for comment by the, prior to the next REMAC meeting, so that we can finalize some of the important lessons learned in the region related to the COVID experience. There are some ongoing housekeeping items that we're discussing related to security and confidentiality. I think the major message for this point of discussion is that all members of QA, the quality committee, are going to sign conflicts of interest and essentially non-disclosure agreements, so that all of, we retain not only privacy related to specific cases, but data that's shared at the quality committee itself. And I am going to. There was one case under review that was referred by, that was requested by a paramedic in the region that we will be reviewing at the next meeting. Okay, I'm going to share my screen. If I can find it. One moment, please. Multitasking, it's lost in the array of things that are on my dashboard. Hold on one second. I apologize. I'm going to be essentially going through the New York City dashboard for our regional AHA measures. So I found it here, and now I'm going to share it. So I apologize to everybody for wasting a minute or so. Okay, so can everybody see that okay?
Yes.
Okay, so just as a reminder, this has been an ongoing project for a number of years. It's been a collaborative project between the fire department and REMAC and the AHA. This was built based on the the region has benefited from funding from the Helmsley Charitable Trust to build this quality improvement tool for STEM, for our AHA mission lifeline measures in STEMI and stroke. And we're essentially utilizing the First Watch and First Pass tool to aggregate performance data for the region. As a visual aid, this is essentially what happens in First Pass, where cases are, put through their analysis, and certain cases are reviewed if they don't meet the specific measures. These measures are then quantified and aggregated for regional use, and essentially this is what it looks like. I mean, this is Sancio, but all 911 agencies in the region are, with the exception of one, has agreed to and is sharing data with regional aggregate, this dashboard. So the EPCR goes in, from Sancio or other vendor and into First Watch. All agency EPCRs record, all the records are available to agency and First Watch triggers, and then all of those PCRs in both detail and aggregate go to the agency level, and the blinded aggregate regional information, it comes to the STEMI and the stroke dashboards. And so what I'm going to put on the screen, the next slide, is this first iteration of a regional dashboard for New York City 2020 for both stroke and STEMI measures. Let me just explain and walk you through it a little bit. This is the first version. It's by no means the final version, but it really kind of, this is, I think, our first glimpse at regionalized data in an active way that hopefully moving forward we can track and trace over time. So the first set of times is really related to the distribution of times on scene for any patients who are thought to be having a stroke. We can look at and track those distributions, but we don't have a set time by which we expect, where there's no evidence-based time that we use to determine whether or not somebody's meeting the metric at this time. So we put the whole distribution there. The next three are whether or not an SLAMS score was performed, whether the last known well was performed, and whether the blood glucose was performed for somebody who the crew deemed was having a stroke and put it as their primary impression. We have three other measures at the bottom of this page. One, the reason why both the appropriate destination for stroke and LVO and the last measure, the appropriate destination for LVO, are whited out is because the data does not yet include telemetry data. So it can't it's only based on EPCR data, so we don't know if the destinations, even if somebody has a high SLAM score, we don't know if those destinations are actually accurate. So we haven't presented those today, but what we can say is that the appropriate destination for stroke patients, anybody who's identified as having a stroke, that over 90% of those patients are taken to at least a primary stroke center. So, it's interesting to see, what are the areas we need to work on? Supposedly, again, we always have to go back and verify that 100% is actually correct, but, it looks like we're accomplishing the key measures around taking care of stroke patients in the field, and then appropriate destination stroke. There are some times it seems where we're missing that, so maybe there's some room for improvement and opportunities there. The regional aggregate scores. So if you're, again, on-scene time for stroke patients, the median performance is 23 minutes, over 23 minutes. And we wanted to use also another way to look at time, which is 911 to destination time, which was just under 38 minutes. So these are things that we can look at and compare to our own services, compared to, we're going to be able to look at it over time and to see how we do. But I think this is very cool, and it gives us kind of a way to use data to drive our performance. We've done the same thing for STEMI. And, you know, there are things here, right? So again, the time distribution, but then contact to 12 lead of less than 10 minutes, which is kind of a regional aim that we've been looking at. We're only at 75% of these patients who have chest pain. So we could do better with that, but it's also interesting if you look at our individual agency performance against the regional performance. And then a 12 lead performed, we're at, you know, and again, in the high 90%, which is good. And, you know, could we get to 100%? I'm not sure, but something to think about. On-scene times, 24 minutes for on-scene time. That's on-scene to scene departure. And then 911 to destination time, looking at the total call, was 43 minutes and 50 seconds. So again, this is the first glimpse of this regional data. We aim to get not only data over time, but individual de-identified agency level data. Once we have all of the agencies in the system, we're going to be able to kind of put us side by side and hopefully help us drive good action performance. So thanks, and I'll take any questions. I hope everybody could hear me.
Yeah, I have a question on this, and I really appreciate this report. It's really excellent data. Go back to the slide that shows destination. It's interesting for us. So you have appropriate destination. The data's not there. Second from the bottom. No, go to stroke.
Let me go. Yeah, here's the stroke data.
Yeah, great. Thank you. So that's great. So the question I have is in the EPCR that Stryker Health EMS is providing, we do have the SLAM score, but are we capturing the exclusion criteria? We have a time exclusion, a patient wheelchair exclusion, a seizure cause of stroke, or a seizure cause of symptoms. We're not capturing that, to my understanding. Is that accurate, or is it something?
It's not captured explicitly in a field in the EPCR. However, the reason why we've wedded it out here is because at some point in the near future, we will have telemetry data. And so that decision at telemetry includes the exclusion criteria. And so that will be included once we have that data that's integrated. And the idea is that these the data from telemetry will be integrated with what we have in the EPCR. So it should give us an accurate sense of our destination.
So Michael, what are they what are the telemetry folks documenting? What are they documenting in? Are they using a proprietary solution, something they've built on their own?
Yes, so we have something called CTS, which is a computerized telemetry system or something to that effect, which has data elements that document the decision from the telemetry side and whether or not and what the exclusion criteria are.
I'll take the rest of my comments offline and we can talk later. Thanks very much.
Thank you.
Michael?
Yes.
Tony Shalish, how are you?
Good.
When the 12 lead information, was that the 12 leads weren't taken on the scene, or they just weren't transmitted to online? Sometimes there's trouble once in a while with transmitting the EKG. So when you got that 12 lead performed, is that it wasn't performed on the patient, or just wasn't transmitted?
Performed, not transmitted. So actually, even though the title of this is STEMI, it captures all, I believe, all chest pain, and so it's 12 lead performed on chest pain.
Okay. Another thing
I have to clarify that and confirm that for 100%, but that's my belief.
I'd like to throw this out for the future for the committee to consider, that I don't know if all STEMIs have to come through medical control. In other words, if an ambulance is in the catchment area of the hospital, a STEMI hospital, and they get a STEMI, maybe we can start using that technology for them to talk directly to the hospital. Because what happens now, sometimes you get took up 2 or 3 STEMIs, and sometimes people actually pull off the side of the road. They're 3 minutes away, and they wait to talk to me or talk to another to tell them to go ahead when the hospital's 3 blocks away. So I think if they're in the catchment area of a STEMI center and have a STEMI, they should just communicate right to the ER. So we should start looking at that for the technology in the future, I think.
I think it's a good idea. It's outside of my pay grade. It's up above my pay grade.
Wait, you're getting paid?
Yeah. Yeah. But I think that's been a kind of back and forth discussion over the years, and there's some merit to it. And so I would defer that to the those, our colleagues at FDNY and at this committee. So.
Oh, so
Mike?
it would be an FDNY and call? You mean that's if they,
No,
it's their call, in other words, or, yeah?
I think we've decided as a region that this is the protocol. And I think that for many years, this has been the case. If it's something that
Right.
we'd want to revisit, I think that it's worth it to have kind of a more formal discussion about it. I think that this is, again, kind of probably out of the scope of this data set, but I hear you.
Maybe we should have a task force on it, because time is myocardium. It just pains me to see people waiting to talk to me when they're 10 minutes, 5 minutes from the hospital. I just can't see that. So I just think it's not, yeah.
I just give so right now, diversions from most categories I'll put directly into the CAD, so they will know what's accepting. For STEMI, that's only maintained by telemetry. So without that call, they don't know the closest currently open STEMI center. That's why, right? So because they'll pull up to the wrong hospital because those diversions are not maintained in the CAD.
Mike,
Brad, I'm sorry, go ahead. Brad,
yeah.
Well, isn't it the hospital's responsibility to notify tele when they're offline? If you're a STEMI center, you're a STEMI center. If you're going to add a service, you need to notify STEMI, you need to medical control that you're offline, right? Aren't they supposed to notify us?
Yeah, exactly. But that is maintained. That's maintained by telemetry. So that's why
we could always put it out over the air. We could always put it out over the air that such and such hospital is down for STEMI, like we do for trauma or do for other things. I just think we need to look at it deeper. That's all.
But,
all right.
Sure. The other thing, this is Nick. The other thing also is that STEMI calls are #1 priorities. They should be done as first call priorities anyway. So there's not a long wait for STEMIs at all.
Anyway, I think that this is beyond the scope of this particular discussion, but I think that if we want to talk about it, we should bring it to Joe or bring it to the fire department for further discussion. That definitely is reasonable.
Hey, Mike, it's Ben Zaber. Just quickly, because you mentioned that telemetry might have data on patients with elevated SLAMs who have exclusion criteria, but my understanding of the protocol is if the patient has an exclusion criteria for LVO, the crew's not calling medical control, they're just going to transport. So if that data is not captured in the PCR, there would be no telemetry call if there is a known exclusion.
A good question and good point, Ben.
Yeah.
But the reality is, right, so what we're going to capture is, right, the true positives going to the LVO centers, right, the thrombectomy centers. And so anything that falls out and doesn't go, right, it would be, so I think that I have to organize that, but maybe somebody else on the team.
Yeah, maybe I can add. I mean, there definitely the exclusion criteria at the moment are not built in as fields in the PCR, and that's done on purpose because we might change and update our exclusion criteria. So there is some uncertainty in this data, and it's understood and it's acceptable. And I don't think there's a specific way around it at this point.
I could argue otherwise, but this may get us into a very lengthy discussion.
I think that the exclusion criteria are written at this point the way they are. As the more we continue to look into the data and explore the data, we might change the exclusion criteria appropriately so. And I think it's for a very large system, like the New York City 911 system, it's hard sometimes to put those things. We do have the SLAMs criteria in the PCRs.
So
and
I think what would be helpful, and that I haven't shared here, is the definitions.
If you just have a single radio button that simply says meets exclusion criteria, and then in the protocol it identifies this exclusion criteria, you can always go back and review the ACR and find what those criteria were. But a single radio button that can be edited in the protocol doesn't have to change the ePCR at any time at all.
I agree, but sometimes just putting a single radio button in our PCR is a very costly and timely effort. I think we really should do this discussion offline.
All right, but I think that the I'm definitely, I think we can end the conversation, but I think that the discussion about how we document definitely fits into how we monitor and measure. And so some alterations and pushing on our EPCR vendors makes sense in some cases. So
Mike, this is Grace. I have a quick question.
Sure.
The 12 lead, are you taking that off the event log, or are you taking it off of whether the EKG is actually attached to the EPCR?
That's another good question, Grace. I don't know, Chief, so I don't know. I'd have to look back at the specifications of the measure, but I believe that it is based on not that whether or not it was attached, based on whether it was documented as done.
Okay, so in the event log. The other thing is First Watch actually querying the narrative too? Because a lot of crews don't document stuff in the event log, but do document what they did in the narrative. So if they're not querying the narrative, they're not going to pick that up.
Understood. I think that they are. I think they have some mechanism to do that. But actually, what I would ask is that anybody have any specific data questions, please email me, and we can, kind of feed those back to First Watch to look at the data, how they're capturing the data. We can share some of the more detailed data, the way that this data is constructed, so that it's open and transparent. So. But happy to have those discussions and give the feedback from this group.
And then just one more thing, just to answer everybody else's question, because I'm very involved. I'm actually the administrator of the EPCR over at the FDNY. One flex field can actually change every single thing on that EPCR. So we don't want one field to be added that's going to have to be asked of every question, because it would have, in order for you to get it in your data, we would need to make it a critical field. And it's not something that we want our crews to ask every single call type. So we have to be very, very careful on what fields we add and where we add them.
Yeah, no, I think that all of these, the details of all of these questions are very important and can be, we have to kind of just, I like the detailed discussions, but we should save it for offline. But
sure.
Thank you. Thanks for bringing that to our attention. And I think that, but again, this measure construction deal is important. It's important in how it looks when we look at it on a dashboard. So thanks everybody. I appreciate your time. I will unshare. Sorry, Joe, give me a minute here. That's the end of the report.
All right, Mike, can you just transfer the host back to me? You get it?
Remind me how to do it.
If you go to the participants list, it should be under more on the bottom. Or actually next to my name, if you look, there's an ellipsis. You can click on that ellipsis and make me the host.
Got it.
Thank you. Okay, next would be the Training Education Committee report. Morty.
Hi, Dr. Schenker. First of all, Dr. Redlener, I know we said this at QA, but it's a huge accomplishment being able to get that data regionalized. So, thank you for your efforts propelling that forward. And Dr. Lai, Dr. Guttenberg, I'm sure would be very happy to see the tremendous progress that was made on that protocol. In terms of my report, the regional training is now in the hands of the Department of Health. Many thanks to John McMillan up there. He's doing a great job assembling it. There are going to be 2 separate tracks, one for EMTs only and one for medics only. The medics will only need to take theirs. The BLS portion, whichever part is applicable, is already built in. Both will generate a certificate when they're done. And John is also helping us build out reporting so that we will know where we stand in terms of who's done. And my understanding is that it should all be done and up and running by the end of the week. And Marie will be sending out separate advisories, one for the EMTs and one for the medics, because it is our understanding that BLS will be done first. And being that the majority of the providers in the region are BLS providers, we want to get that out to them first to get started. To follow up on that, Dr. Schenker and I have discussed setting up regional like town hall question and answer sessions. So I'm going to be setting those up as well. So those will be going out, and there will be 1 to 2 sessions per week between now, and we'll probably run them for about 4 or 5 weeks.
Okay, and any physician who wants to help with that, I would greatly appreciate it. So
yes, please.
The more people that can host these town halls, the better it will be. All right, I see 2 hands up. Just I'm sorry, Morty. Let me let you finish first.
Sure. That's it. That's all we got. Yep, that's our priority, is getting this training done.
So I see 2 hands up, and I don't know if these are old or new. Anthony, you had your hand up. Shalish.
No, that was for the STEMI.
Okay, great. And then I guess Paul just took his hand down. So.
Yeah, I was residual. I apologize.
Okay, no problem. Listen, before we move forward, I just wanted to say one thing. The New York City Fire Department and the REMAC were selected to be the 2020 American Stroke Association Community Conscience Award recipients. And this is very, very strongly due to the work of both Michael and David, who will be accepting the award actually on Friday, October 30th. So I really want to thank them for all the work they've done on the SLAMS project, on the stroke project. All the benefits that we are reaping in the area, hopefully, will be benefits that are reaped nationally by other cities and other agencies. So I really want to thank David and Michael for their amazing work on this stroke project. Thank you, guys.
Thanks everybody for a real collaborative approach on everything. It couldn't have been done without a lot of people's support. So thanks to all of us. Congratulations to REMAC and to the fire department for getting the award.
Yeah, I agree completely. This is a collaborative effort. It's not just 2 people. It couldn't be done alone.
Did the lion's share of the work, so thank you. Okay, any questions for Morty about training and education? I will say that for those of you who are agency medical directors, I will ask you, I have told the state in no uncertain words that our region will be completely ready for the January 1st implementation date of our protocols. That means we have 2 months to ensure that all of our providers are trained in the unified protocols. The fire department has done an in-person training, which I believe is completed, and they've done a great job with it. A lot of that information is now in the online version, which is for every agency other than the fire department. And I think that with the town halls will really give an interactive, training to our region that probably will get this done in the 2 months that we have. So I ask that you all please stay on top of your providers to make sure that it gets done. Okay, that said, let's move to the RTEC report. So Dr. Simon had submitted, and Dr. Simon, if you can unmute yourself, had submitted to the region and to Dr. Reisman a question about about transfers to trauma centers, specifically pediatric trauma centers, but all trauma centers in terms of when a patient is in cardiac arrest. And I believe we did make a regional change. I think it was a year or 2 ago. It might be in the unified protocols that unless the patient has an unmanageable airway, they should be going to a trauma center, even if in cardiac arrest. That said, I know that there's some anecdotal cases that you wanted to talk about, so I'll let you present the RTEC data, Dr. Simon.
So thank you very much, and good evening, everybody. Thank you for putting up with me. So we found, and we know pretty much that about 30% or 40% of pediatric trauma is being brought to non-pediatric trauma centers. And with the density of trauma centers in the city, we think that that's probably not necessary and doesn't necessarily benefit the kids. And that particularly has to do with a child who has either severe traumatic injury or even traumatic arrest, that, you know, the state guideline was that you should bring a kid to a pediatric trauma center if you can do it within 60 minutes. And when we discussed this at REMAC, we said that doesn't work for us here in the city, and we're going to knock it down to 30 minutes. And that still gives a lot of time for EMS crews to bring children to designated pediatric trauma centers. And I just think that even though it may be easier to bring a kid to either a non-trauma center or an adult-only trauma center, the expertise that's involved with you know, dealing with a critically ill kid really, as far as airways concerned, lines are concerned, and things like that are concerned, you really want to have that kid in a pediatric trauma center. And the other piece of this is, I don't think anybody on this committee or in the city would disagree that having pediatric trauma centers are the right thing to do for the populace. And not supporting the pediatric trauma centers such that the pediatric trauma centers don't have adequate volume to maintain either level 1 or level 2 status really defeats the purpose of what we're trying to do, which is provide the best level of care for the people in New York City. So I think we need to do something to enhance transport of pediatric trauma within all 5 boroughs. There are pediatric trauma centers in all 5 boroughs now. And I think it's important that we support those centers and that we transport kids to those centers. And one of the things that would support that is Eric Cohn was just showing me the new protocols, and the protocols list all of the trauma centers within the city. And it still lists a bunch of trauma centers as pediatric trauma centers that are not pediatric trauma centers anymore. So the list of trauma centers needs to be updated in the protocols. But I do think we really have to work with the EMS providers that it's really better for a kid to go another 5 minutes to get them into a pediatric trauma center than to drop them off at the nearest adult center that are just not going to be able to manage a critically ill kid as well as a pediatric trauma center.
Joe, I'd like to raise my hand when I can.
Yeah, sure. Go ahead.
Yeah, you know, it's very interesting that you bring this up now because we actually were looking at that again. And quite honestly, when we only had the 2 pediatric trauma centers initially, New York Presby on the west side of Manhattan and Cohen's at the Queens Nassau border, you know, obviously trying to get there with a pediatric patient was very difficult for us. You know, and then we had to go to the closest trauma center, adult trauma center for them. And, you know, that was allowed by the state, and we know the times have changed and things like that. When Maimonides came on in Brooklyn, we thought, great, now we have 3 centers. So obviously we want to try to get them to the appropriate facility. Now, from a systems perspective, we now have 8 or I think even 9 pediatric trauma centers. And from the systems perspective, I thought that's great. There are more centers that we can get these kids to. But what's happening is, as you mentioned, the more they're spreading these cases out now to a point where some hospitals, pediatric trauma centers have said to us, we're not getting the volume. We don't know if we can sustain being a pediatric trauma center based on ACS criteria, number of cases. And luckily, for the most part, there's no knife and gun club for the peds patients. Although, unfortunately, in New York, we had that 6-year-old shot during the Juve the Juve celebration, and the 1-year-old who was shot and killed in Brooklyn as well. So we actually started looking at, you know, what can we do to say maybe because there's 8 or 9, I think there's 9 pediatric trauma centers in our region. Can we now change it, look at changing it to, you know, pediatric patients going to the closest pediatric trauma center? So we're mapping it out now. And the problem that we still have is, you know, like you said, 5 minutes going beyond the adult trauma center, 5 minutes, I think we're very comfortable with. 35 minutes, even 40 minutes. The hour, which the state allows, I think was a little bit problematic
for those of us thinking about the system. So when we map it out, even with the 9 centers, the problem right now, and we're still trying to get it mapped out with times, Bucklan with Maimonides, the only pediatric trauma center, and Central Queens, where now it's either going to the Cohen's, the Nassau Queens border, or trying to get into the city, or maybe even Jacoby, technically going north to the Bronx. That's a little bit of an issue where even though there are 9 centers now, it's saturated in Manhattan. Staten Island has 2, but again, Bucklan and Queens in particular, Central Queens, is potentially problematic. So I think we definitely should reevaluate this, relook at this, and see about getting these pediatric trauma center candidates to the pediatric trauma center. So we're in agreement with you. But now it's the comfort level of, like you said, like I'm saying, 5 minutes beyond the adult trauma center, I think we're all comfortable with. But if it's literally going to be 58 minutes, are we comfortable with that? Because now you're putting a crew in the back of an ambulance with a critically sick, traumatic pediatric patient that they're trying to BLS manage, and in a lot of views of crews, they're like, I'd rather just get the patient to the adult trauma center, let them stabilize and then go. But in the long run, that may be detrimental. So this is something that it's great timing. We're looking at it internally now.
Thank you, Glenn. Anybody have any other questions?
Hi, this is Brad.
Brad, go ahead.
Hi, Dr. Simon. I agree with everything you've said and Glenn said. But I'm surprised by that data that you're having so many are not currently going to peds trauma. And I wonder if that data you're quoting is from the hospital end, where I suspect that they may be getting patients who have some trauma who are not meeting the EMS trauma criteria. And that's why it might seem that there are so few going to the pediatric trauma centers.
Well, this is based on Sparks data.
Right.
that looked at, that looks at all admissions. But
So I think that criteria might be actually a little different than what the field is using, and that could explain some of the numbers.
I would say that maybe what we need to do is for members of this committee to come to the RTAC, and maybe a subcommittee of RTAC would be to discuss and evaluate what the best recommendations are. Meaning, for a patient who's in a traumatic arrest as a pediatric patient, if you look at the data, there probably isn't benefit, even if it takes longer to get to a trauma center, there isn't benefit to going to a closer ER. The survival rate at a closer ER will be the same, will be much less, regardless of, if you get to the pediatric trauma center, the patient has a statistically better chance of survival, even if it's a longer distance. So I think that this definitely warrants further discussion and possibly changes to our trauma protocols going forward. But I think that Brad is right. What we've always found is that our trauma criteria and the Sparks data that comes out on the back end are different. And the things that gets included from the Sparks data is stuff that we would not consider a trauma on the front end, and therefore the numbers are always different. I think that this should be discussed further at the RTAC though. Art does also need his hand held, so let me hold his hand. Art, go ahead.
Thank you, Joe, and Ron, thank you for your very incisive summary of the current situation. This is not just a local problem. Nationwide, a lot more children end up not going to pediatric trauma centers than ought to be going there. And there's good data in the literature to support that. Ron is absolutely right that we need to find a way to improve triage of kids to the appropriate centers. I'm also sensitive to Glenn Aceda's point that we do not want children who are truly in extremis to be traveling, up to an hour, to get to a trauma center, to get to a pediatric trauma center, if they're truly in extremis. But I do think we can probably come together on some kind of a time frame that makes sense for the boroughs where pediatric trauma centers are scarce. Clearly, every effort should be made to ensure that there are centers in every borough within reach. But this does require further discussion. I would suggest, Joe, that in the past, when we had issues such as this that touched on both pre-hospital transport and trauma care, that we formed a joint committee between REMAC, or joint subcommittee between REMAC and RTAC to discuss those issues. And I would just suggest that this might be a perfect time to utilize that mechanism. Thank you.
Thank you. All right, Doug, and then we'll move forward.
Wait, I can't raise my hand either.
Michael, you did have your hand up before. Doug, you have to wait 1 second. Mike, go ahead.
I would like to use this opportunity to think about how we document and identify major trauma in EMS. I've always found in the EPCR it's very difficult to search for appropriate trauma cases. There's ways to do it related to the CDC guidelines that kind of get calculated on the back end. But I think if we're talking about identifying trauma and tracking it and seeing where it goes, it might be worthwhile to kind of think through together, like what it is, how do we identify, what are the best practices in documentation around that? Because I find it really, really hard to really, identify the appropriate patients in the pre-hospital setting.
Thank you.
I agree with that. Thank you, Michael.
All right, Doug is going to reserve his comments for the next RTAC meeting. So is there any other questions or comments?
I'll take it now, Joe.
Has his hand up.
I'll take it. Just to echo what Michael said, I brought this up at RTAC previously, and I was going to bring up the next meeting that we need to simplify the trauma center criteria. If you ask anyone to recall you on this committee, I don't think anyone can recall all the criteria. Some is your GCS. I know it's a requirement for ACS to have GCS, but the reader reliability in terms of is like for physicians is 30 to 40%, and then 40% is being generous. So I think we need to simplify things. I understand though there are certain criteria that I guess we need to follow for the region for the trauma center.
Thank you, John.
Yeah, I think that one of the things that's really important in this equation is to look at over triage. And look at to what extent we're seeing over triage as well, because it's really about balancing under and over triage to the appropriate centers. So I think that part needs to be taken into consideration, especially if they're doing, especially if you're doing as kind of what has been suggested is that people are looking at the ISS, and that ISS is maybe it doesn't really, there's no way to predict the ISS. Based on the mechanism all the time. So thank you.
Okay, thank you. All right, any other questions for Ron or on this discussion? If not, we'll just move it to RTAC and let them report at the next meeting. Okay, thank you, everybody.
Thank you very much.
No problem. Thank you, Ron. Okay, I wanted to add a subcommittee that kind of we've taken off the list for a little bit, but I think with the timeline that's coming up, it's important that we revamp this. About a year ago, we were working on ET3 and reviewing the protocols for ET3 as well as the operational components and so on. I think it's important now, considering the upcoming timeline, to institute that subcommittee. I believe that tag was chaired by Jeff. So I asked that we can reconvene that meeting. I know that Kevin and Dr. Prezant are both on the call. I'm going to let them both say a little bit. And then if we can reconvene that meeting, I think it'd be important to make sure that we're all on the same page going forward. I know that from the state perspective, they do need a list of alternative destinations so that they can add them to the NEMSIS database for inputting. So that is an important part that we definitely need to figure out so we can get up to them. I spoke to Ryan about this, and he is more than willing to help us get it into Sparks when the time is right. So Kevin, and then Dr. Prezant, and then Jeff to wrap it up, and we'll move on. So Kevin?
Sure. Thanks so much, Joe. Hi, everyone. So I guess I'll just do a little bit of background, and I'm happy for Dr. Prezant to tell us more about the sort of the regional efforts. But as background, I think most people are aware that the program is called Emergency Triage and Transport, or I might have those T's in the wrong order. But the program it allows us to do treat and release from the field treatment in place from the field via telehealth or with a on-scene qualified healthcare practitioner, and to do transport to alternative destinations. As a reminder, we had approved a protocol, I think last year, roughly the September-October meeting, and about, I think 11 applications went in as a region to apply for ET3, and we were accepted as the region. It was originally supposed to go live in May, got put off because of COVID, and then the new start date is January 1, 2021. And the opportunity, the challenge now is just to work towards implementation. There should be at least one or more people from each of the 11 agencies that have received information from CMMI, Center for Medicare and Medicaid Innovation, with access to a portal into which there are a few deadlines that we should be aware of. One is November 15th, which is coming up right around the corner, which is to submit a implementation plan. Another deadline is December 15th, which is to submit a participation agreement. And I believe a couple of days after that is the deadline to submit your alternative destination and partner list for telehealth. So a couple of things that are due from that perspective. And then I guess more importantly, as a region, we just need to think about, okay, how are we going to get, besides the formal requirements from Medicare, are there, what are the different things we need to do to get this, to work? Turning the protocols, there's the EPCR work that I know FDNY has been talking with Health EMS about. There's training of our providers, coordinating with our telehealth partners and our alternative destinations. So I think, that's just the cream, the top of the list. I think there's probably more, to get into. So I do think that the committee should, get back together and hopefully, I think very soon bring forward a number of, things for discussion. Some may need approval, some just may need regional coordination. And so I think it's great that we're discussing it here.
Okay, thank you. Dave, Prezant?
Yeah, so that's a nice overview, but let me emphasize a few of the details that are behind this. First off, while ET3 has now gone back online with a proposed start date that the federal government will reimburse, January 2021, the region is absolutely not prepared to begin on January 2021 because the CAD system for the 911 New York City region needs to be updated to have the alternative destinations listed, to have the telemedicine partners listed. The EPCR work has already been completed. The only thing that needs to be done, thanks to Chief Cacciola and to Sancio, the only thing that needs to be done is to add the list, actually fill in the drop-down list with the specific names of the alternative destinations, but all the programming has been done, and that has been shown to all of our REMAC partners at a group meeting, and we're happy to have another group meeting again to show that. But the CAD system has not been updated. In addition, because a lot of the conversation between the EMS provider and the patient occurs outside of the ambulance, in their apartment or their work location or wherever, and there are often family members there, the discussion of which alternative destination, how close it is to the patient, how convenient it is, et cetera, needs to be displayed not just on the MDT in the ambulance, but on some portable device that the ambulance provider is carrying. To achieve that, one could just show a list with GPS, but we would like to do better than that, because we have promised, and it is a requirement of ET3, that the alternative destinations are allowed to go on diversion. So to really demonstrate what is the closest alternative destination and to adjust that for diversion and for ambulance redirection, though I hope that'll never happen or be needed, we need a mobile mini version of the CAD. The requirements for this are not extensive, and we're not talking about a year's delay, but we will not have it up and running on January 2021. Also, I'd like to remind the committee that there has already been an agreement at REMAC that there would be one list of alternative destinations that all the ambulance providers participating in the 911 system would utilize. This is a critical issue, and CMS, in their documents that they sent each of the ambulance providers that we now have to respond to, seems to have misunderstood this, in that they have geographically narrowed for some of the providers the alternative destinations to match the borough or counties, would be a more appropriate word, that they serve, not realizing that they can be sent over the bridge to a nearby county in New York City based on just regular 911 system traffic. So it has to be, for many, many reasons, it has to be one list of common alternative destinations. These alternative destinations have to be willing to accept all of our patients, not just Medicare patients that are paid for via ET3. And CMS needs to modify their documents that they sent to us. We will be having conversations with CMS, and we will be starting to outreach to the alternative destinations that sent in letters of interest to our original application. And we will be happy to have REMAC participation in those meetings so that we can find out whether they truly were interested in participating. You send in letters of interest to a lot of RFIs just as part of your standard business plan. Are they willing to accept what they have to be willing to accept, which is Medicaid patients and non-insured patients? That we are, as one region, are committed to treating all patients identical. The healthcare network, we want to bring them to the alternative destination that is reasonable distance, that is part of that network. Otherwise, we bring them to the closest appropriate alternative destination. These are things we have to work on a little bit more with REMAC, but we have to have these meetings with the alternative destinations to see if they really are our players. And we have to modify the list, and then we have to submit that. So there's a lot of things that are going on right now, but there are some critical issues to be identified way before we could start on January 2021.
Thank you. All right, so I think that Jeff, I ask that you can work with Marie to set up a time to get that going.
Yep,
and,
I'll do that.
Further offline.
Thank you.
Okay, any other questions about that discussion? I think it's better that it be held as its own tag, because I think it's a very lively discussion that we don't want to have right now. Okay, thank you. All right, we're up to the regional council update. Dr. Langsam.
Okay.
We can't hear you so well. Your speaker, your microphone is not working.
Me?
Now we can hear you.
Someone else was making noise. Okay. The REMSCO met last September. We approved Dr. Harris as a pediatric physician on REMAC. There were no applications to transfer operating authority. There was one new application for the expansion of Glen Oaks VAC. And in fact, the ambulance committee had reviewed it and marked it as being now it's complete, and a public hearing is now set up for this. There was significant opposition from representatives of the former Bayside VAC, which surrendered its ambulance in 2017, and they woke up now and decided that they wanted it back, but it's a little too late at this point. Marie already mentioned that Bedford-Stuyvesant is going to get technical assistance as stipulated by New York State DOH enforcement, and the leadership of the District 4 and 18 will deal with that. However, Bed-Stuy has to reach out to them and work with them. They're not going to run after them. The mental health team is being reactivated. We approved a letter to be written to New York State Commission of Health to support funding for REMSCO and program agency, which apparently we're pretty desperate for. You already heard everything about the T&E committee, so thank you for that report. I won't repeat it. And the next REMSCO meeting will be on October 27th, next week. See you then.
Thank you. Any questions for Dr. Langsam? Okay, hearing none. There was no CMAC meeting since our last meeting. I believe the next meeting is going to be in November. So we'll skip the CMAC update for right now.
December 8th and 9th.
I'm sorry?
December 8th and 9th.
December 8th and 9th. Thank you very much. Appreciate it, Lou. And Jeff. Okay, finally, the last piece of unfinished business, Marie has it on the agenda as new business, but I will put it up for everybody, is the second reading of the bylaws. There was some discussion about adding a informaticist, and the bylaws committee felt that there's enough representation in the other seats for a informaticist to fit into, rather than having a dedicated informaticist. So I'm going to put this up so we can have our second reading. If you give me a second, I'll share my screen. Gotta find it. Okay. Okay, so this is the second reading of the bylaws. There is no change from the first. I will go to the membership because this was the points that we had discussed. Again, none of these numbers changed. If you see here under the fire department, there's 7 physicians that are voting members, 1 chair, commissioner or non-physician designee, 2 EMT or paramedics. Greater New York is 4 physicians and 2 EMTs and paramedics. Downstate is 1 medical director, 2 EMTs. And then over here, there's some dedicated seats I want to just point out. So you can see that under the EMS community seats, I'm sorry, under the training here, paramedic program medical director. So this is training centers. We have a municipal FDNY seat as well as a non-municipal seat. And under medical standards, we have a municipal seat and a non-municipal seat. This is to keep a balance throughout our region and make things make sense. I would ask if you guys have any questions, just hold them. I'm just going to quickly go through this. Period of 2 years, you can be reappointed. The appointment process from these, if it's a constituent organization, it's an appointment. If it's an at-large nomination, it's a voting in process. For the purpose of nominating community seats, the nominating committee will review these from the community. RTAC can submit nominations for trauma centers or pediatric trauma centers. There is, by the way, I believe, a dedicated pediatric trauma seat now, if I remember correctly. Yes. So trauma surgeon and pediatric trauma surgeon, besides the pediatric physician, which I think is higher up. I apologize. Anyways, back down to here. Psychiatric emergency physician, REMAC shall seek candidate applications from regional psychiatric facilities. Applications from pediatric emergency physicians for peds. New York City Department of Health Mental Hygiene. It's a nomination from the Commissioner of Health and Mental Hygiene or his or her designee. And emergency management, it's a nomination from the Commissioner of New York City Emergency Management. It's a non-physician seat, so it cannot be a physician. This is important, and I want to make sure everybody knows this. One seated or representative may be removed by the nominated constituent organization or 2/3 written vote from the entire membership. And more importantly, members with more than 3 absences from regular meetings of each REMAC year shall be considered to have voluntarily resigned. They'll be notified in writing. It is important to understand that, you know, especially now with Zoom, we don't meet that often, and it's important that people are present and involved. It's the same as being on video when you're on the Zoom calls. I think it adds to a level of involvement rather than calling in. You know, take the time to find a place where you can be by a computer. You don't have to come to REMAC, so that should be doable. And again, you know, if you're not going to participate, there are plenty of people who want to join who will participate. Alternatives, physician alternatives may vote when their principal isn't present, and it's permissible for each member. So for example, if a fire department fellow can be an alternate for a fire department medical director in the event that they are not able to attend on a deployment, have a meeting, whatever it might be. Okay, only physicians are eligible to vote, majority of the total voting membership, whether seated or not. So it's a majority. This is essentially a quorum is a majority of the total voting members, and a positive is a majority of the total voting members, whether or not they're here. Okay. And we can use an electronic ballot if it can't be, if we can't get a quorum for 2 meetings. All right, the officers, this is set, and the committee structure is the same. Nothing has changed here. There can be ad hoc committees. There can be, again, I think that the chair is used generically here. I would hope that, and I know I would do this, but I would hope that the chair would work in conjunction with the executive committee to make any of these decisions and then report that to the region. So 2 consecutive, these bylaws may be amended at the minimum of 2 consecutive readings and then by a 2/3 vote. So at the next meeting, via 2/3 vote of the voting members of REMAC, we can enact these bylaws. And the reporting relationship is decisions made here must be read to the REMSCO and to the CEMSCO. For REMSCO, it's only informational. For CEMSCO, it's by statute and it's reported. Any questions about that? I know I went through that kind of quickly, but I wanted to make sure that we got through it before our 8 o'clock deadline where we turn into pumpkins. All right, I don't see any questions. Anybody raise their hand on the list? Does anybody have any questions from the floor? If you can unmute yourself and ask them, I would appreciate it.
Friedman asked to send it out, Joe.
Friedman asked to send it out. Okay, yeah, sure. We can definitely, this did go out. I believe it went out 2 meetings ago when the bylaws were first introduced, but we can send it out again.
It also went out this time. I sent it out for every meeting.
It's in the meeting packet that got sent out. All right, so Matt, if you just take a look at the meeting packet from REMAC, it's in that packet. Any other questions? All right, well, if there are no further questions, I will entertain a motion to adjourn. Our next meeting, I believe, Marie, can you tell me the exact date?
The next meeting will be on November 17th. I mean, November 10th.
Just to clarify, by the way, the meetings were initially put in a calendar in person because we needed to book a room. The next meeting will continue to be virtual. So just so everybody knows.
Yeah, and please check our website because if there are any changes or any additional information, we have them in the calendar on our REMSCO website.
Okay, a motion to adjourn?
Motion to adjourn.
All right, thank you, everybody.
Thank you.
Appreciated. Have a great night.
Joe, you're the host, so.
I will cancel. I will end it.
Okay, thank you. Bye.